Good morning. So welcome all. It's happy to see EUS enthusiasts from all over UAE, and of course our international guests who have come to train us about EUS. So I extend warm welcome to all of you for being here. And at the outset, I would like to thank AEG for helping us organize this basic training in EUS, which is very, very important part of beginning to start doing a EUS. So as we all know, EUS is a fusion of endoscopy and ultrasound, and it's putting two techniques together. We are used to doing endoscopy, and EUS is another modality. So it takes some time to get trained, and it takes decades to be close to the experts who are here. So AEG is basically Asian US group. It's based in Singapore. It's an academic interest group, not for profit. And it has been there for almost a decade. And its main aim is to promote and train people for US in the Asia Pacific region. And it also encourages collaboration amongst various academic groups and various hospitals. And I want to extend warm welcome to Professor Dong Wong Seo, who is from University Ulsan, and he is the chairman. He has come all the way from Seoul, South Korea, to be here with us. I welcome my guru, my mentor, Dr. Vinay Dheer, who is the chairman of Institute of Liver and Biliary Diseases at Mumbai, and I've been his student for last 20 years and continue to do so. And also Professor Rungsun is the director of Center of Excellence and Innovation in GI Oncology, Faculty of Medicine, Chulalongkorn, University, Bangkok, Thailand. So I really appreciate their effort to come in these difficult times to do multiple COVIDs and be here with us to train us and teach us. And also appreciate Olympus from Singapore, Mr. Dixon Pang. He has taken all the pains to come with his models and equipments all over from there. And of course, AG and Flora for her effort. And I think we'll start the meeting with the first lecture from Professor Rungsun. Oh, the mic started now. So Professor Rungsun, as I told, he's the chair of Center of Excellence and Innovation in GI Oncology in Chulalongkorn University. I hope I'm pronouncing it correct, Rungsun. So he has graduated from Thailand, and he has been excellent. He has been trained in the US, in Chicago, and his main area of interest, of course, is ERCP, cholangioscopy, and he teaches EUS as well. So without further delay, I'll invite Rungsun to start his talk. So EUS is the first step of EUS, and I still remember 25 years back, Dr. Dheer used to tell me that if you have resources to buy one EUS scope, buy one linear scope. If you have more resources to buy EUS scope, buy second linear scope. And if you have more resources, then you buy the radial scope. But it is, of course, required. It gives us anatomy like a CT scan, and it helps us begin. And it's really, really very important in certain situations in the lumen, which Rungsun will tell us. Welcome.
Okay. Good morning. Thank you, Yokis, and the NMC team for inviting me for this very, wonderful meeting. I think this is my first field trip after the pandemic, and happy to see many of you here. I mean, EUS, we just said that for the other one is just for decoration, or is this real? So this is my job to find some room for you. Maybe, I mean, Dixon, think about this. Buy 2 linear and you get 1 free radial scope. That's the way it can be useful. So let me walk you through EUS to, my opinion. My disclosure is, right, I teach some EUS, but I don't do myself. But I still see the use of this EUS. As Yogit mentioned, For those who want to get started, this is one of the simple thing for you to understand the anatomy for you move on, because these days people talk about more, therapeutic EUS or some intervention with the linear scope. And I just talked to Dongwan. I have only some 30 slides. He got 100 plus. So the rest will be yours. Okay. Currently, actually, there are many more models than this, but this is the three, the big brand that we do have in the system. As you can see, that always come as the, dual, linear, and the radial. To me, the only different I can talk is the orientation in terms of scanning. As you see, that's the scanning of linear is more like vertical or coronal to the structure in the thorax or abdomen. But radials, think about this. Just like you look at cross-sectional imaging, like I think the easiest thing to go is CT scan, and you see, I think, closely and more detail. But as people realize that these days, these technology getting better and better in terms of resolution. So we probably don't need this scan that much, but I think there's still some room for this radio EUS. Talking about disadvantage of this, but the most important is the technique. I think is so simple. Even the basic endoscopist or somebody who doesn't do EUS like me can do, just push and pull and just start seeing the structure and find the anatomical landmark and see the things. So first, let's talk about the the polarized system. This is from Professor Toby. The easiest thing to do when I talk about EUS is to call Toby. So Toby, give me some slide, and then next time you see him. So good things about the radar one. The different things I want to say is the endoscopic view, because different from the other two brands. The Olympus one is more like oblique view, similar to the linear. So what I see that for the beginner, when they move in, it's simple and easy with the other two brands to go in directly, just like standard gastroscopy. But for the Olympus, you have to be careful. It's not completely like the side viewing and endoscope, but it's oblique. But for those who are already familiar with linear system, there's no problem. Of course, they have some working channel, but usually we don't do it very much. And the only different from linear is we put the balloon that we can see the structure clearly. Because I think, to me, this day we are focusing on the wall of the GI tract. Is stomach, esophagus, and rectum, and some use in the Panther system in terms of diagnostic. To my practical point of view is to exclude CBD stone for those who doesn't want to go to the ESP, which can cause more problem if you see no stone and you create pancreatitis after your cannulation. And I don't know about this country. The problem in my institution is when we call for MRCP, it doesn't come right away, a week or 2 weeks. So put the EUS scope, maybe simple thing, and it's more handy to many basic endoscopies compared to the linear EUS. So the two exclusivity stone, this is the most used in my institution before we move on to ERCP. So it's about I think you probably know about the ASGE criteria regarding when to perform ERCP, when to perform confirmation tests like MRCP and EUS. And to me, a little bit more advantage in terms of CBD slush or those small stone that could be missed by MRCP. So I think this is what we use. Many times we've been called by the neurosurgeon or colorectal surgeon to perform EUS. section, and you usually start from the distal antrum and pull up to the top part in the cardia. Technically, because of the target, we usually want to see the wall of the structure, let's say the gastric wall. So please fill the lumen with water until the all rugal fold becomes separated, and you can see the structure better like this one. Many times we recommend you to use a balloon, and air bubble is the problem. So try to avoid that, but don't use simeticone because it causes artifact. This is called hyperechogenic artifact when you perform, and also cleaning the scope channel become a problem in the US. This is one of the the difficulty, and they try to discourage people to do that. Either you use 7.5 megahertz or 12 megahertz. Usually, when you use the low megahertz, you can be a little far from the gut wall. So usually we recommend about 1.5 to 2.5 cm from the gut wall. For the higher frequency, you see more detail of structure, but you need to get closer, especially the mini pro. For those small lesions, as you can see in this one. So for those small tumor in the antrum or in the esophagus with stricture, this small probe is very helpful. So you have to get a little bit closer, about 1 cm from the structure that you want to examine. So this is the standard mediastinal anatomy. I think always put aorta around here, 5 to 6 o'clock. And you can see the aortopulmonary window, and you can see the isogos vein, or this is the, I think, the thoracic duct, when you talk about this with the pulmonologist. But I mean, this day, in my opinion, people are using more of the coronary imaging, but still some of the pulmonologists prefer to perform EBUS plus EUS in this area. So talk to your team, what do they need? First, when we get started, as I mentioned, the usefulness of radial still over other thing is the structure of the wall of the GI tract, especially the stomach. Look like you have the double cheeseburger, the white, the black, the white, the black. So basically, this is the representing mucosa and the muscle. The black one representing muscle. So the first layer is the MM, and the fourth layer is MP, and the white one is either mucosa, submucosa, and serosa. Same the concept in these structures. So remember this file, I think this is easy, and then you can use, because this is very important for us to distinguish many etiology when we see subepithelial lesion before we perform to the next step, like from Poseidon 1, like EUS-FNA or FNB. Many of these structures may not need to be poked. Again, just want to say that the MP has actually 2 sets of muscle. The inner one is the circular one, and the longitudinal one. So if you have the very detailed high frequency, you can see these 2 structures, but technically don't need. Just make sure that you see this thing in the layer 4, and then you can think about what to do next in terms of treatment. Talking about the layer, next thing we have to talk is about the echogenicity of the structure you see. Anechoics mean that this is representing the cyst or water. Hypo, or this means that the echogenicity is equal or less than 2nd or 4th part. I mean the layer. Hyper is this equal or higher. This is compared to the 1st, 3rd, or the 5th part. Iso is mean equivalent. So that's what can be, the pathology there. When you look, if you look at the layer and the echogenicity, you can, make your imagination. Look at the easiest one is this layer. Generally, if you see things in the 2nd or 4th layer, these are the tumor of the muscle, either cyst, leiomyoma, or granular cell tumor, sometimes, or more it's much rarer is schwannoma. But if you see things in the third layer, that could be so many things, starting from even granular cell tumor, glomerulus tumor, and something in between, urinary gland tumor, lymphangioma, lipoma, fibroma, or cyst. So you have to take a look at the echogenicity. If it's anechoic, either it is cyst or lymphangioma, and the bright one is only lipoma. The rest is somewhere between hypo or isoechoic. So this is other thing that somehow or sometimes you need other information, or you may require tissue acquisition by, the working. Again, if you go by layer, you can go from the top part. Usually the mucosal thing, you can use image enhancements to help you in terms of finding the polyp. Either this is, neoplastic polyp or hyperplasia. The rest is probably close to the mucosa, but there's no structural change. So you have to go see deeper. And this is the same as I mentioned earlier. So to my opinion, the one that we use quite a lot this day in terms of the treatment plan is the, muscle tumor. Either it's GIST or leiomyoma or some other thing. And the rest are extrinsic compression like lymph node, malignancy, or pseudocyst. To make or combine this thing together, first, to me, as the practical use of Radial or other, the EUS, the user is to look at the echogenicity and the layer. By putting this together, if you see hyperechoic, usually it's not that deep. It's around third layer, it's lipoma. If you see, anechoic structure, it's lymphangioma or cyst. The rest depend how the appearance. If you have the crater, if you just location, you can call it the ectopic pancreas as a dimple over there, like leiomyoma, just metastatic tumor or some other thing like carcinoid syndrome. And these usually representing as hypoechoic structure. So talking about that, these are the subepithelial lesions that have malignant potential. So these are the things that you have to make sure that you don't miss that, because this is a chance for cure for those small lesions. Neuroendocrine tumor, GIST, lymphoma, granular cell tumor, glomerulus tumor, adenocarcinoma, sarcoma. So let's see some of the example of these, lesions. So talk about leiomyoma. Although they all are leiomyoma, but some could be GIST with low risk or high risk. The just simple leiomyoma, you see that the mass usually very homogeneous, and its echogenicity is similar to the surrounding muscle structure. So you can tell this. But if you look at this one, it starts to be more inhomogeneous, and its echogenicity is somewhat a little bit higher than surrounding muscle structure. So this probably just with low risk potential. But for those with high risk potential, like malignant one that have a high, the level of malignancy, you can see marginal halo and many inhomogeneous and irregular border in terms of the spot, as you can see here. This is the predictive, point before you perform the tissue acquisition by FNA or FNB. Oops, sorry. Can you have the lecture view? Can I move on? Yeah. Okay. Okay. So this is another, the example of just from, MP layer as a fourth layer, as you can see that here, small and large one. Okay. What is this? Ectopic pancreas. It's on the third layer of the pancreas. Of the stomach wall. These are the things in the second and third layer lesion. There are three of them. This is lipoma because you see that very bright or hyperechoic finding from your scan. What about this one? This is granular cell, the tumor here. Glomus tumor. Sure. Okay. No problem. Okay. Yep. Okay, these are the the tumor that we talked, and this is the pancreatic rest. I think we showed it to you earlier. So what about this one? This is the from endoscopic point view, you see some elevated lesion with central dimpling and in the duodenum, and this is the tumor that have hypoechoic from the third layer. So what is this? Carcinoma. See that include the lymph node, but technically these are the patient because it's producing hormone. You usually have symptom or presentation first, but for those non-functioning tumor, you may have to take a look and take the the tissue acquisition. What about this one? Lymphangioma, because of the almost hypoechogenicity, and this is probably there's some structure in there. From this you can see. And this is the Brunner gland tumor in the third layer. Actually, this one got some pedunculated polyp pattern, and this is after the resection. So there are certain conditions. It's not tumor. Patient come with pain, fever. This is the case of phlegmatic gastritis. Interesting thing that sometimes you can see foreign body in there, and this the structure you see it because of the acoustic shadow could be air inside the lesion. So after this, if you do puncture or unroot the mucosa, you can see pus coming out. So this is a phlegmatic gastritis. So talking about the next move in terms of structure and examination, I think easier to follow by X-ray imaging like CT scan, starting from the home-based lesion. Gastric station, you put the aorta here, the same as CT scan. So right here, gonna be IVC, and this is the left lobe of the liver. See, and you push in slowly, you start seeing this structure. I think in US, you guys call as bell tail here. So what is this? Same as this one. Sorry for this quite small picture. Hepatic artery, coming from celiac, trunk, and this is splenic artery and also splenic vein. So you put in and slightly clockwise a little bit. You move aorta to the left side. You start seeing this structure. See pancreas, this area and the left kidney. I think for me, who doesn't understand anything, when I map with CT scan, I understand this thing better. What else? I think EUS, many of them are golfer, like John Wan. So when they call about this, I said, oh, what is this? So if you look at the confluence of the venous system, they call it as a club head. See this one? And where's the golf ball? SMA. And the shaft is splenic vein here. So this is a standard structure. Again, when you map with CT scan, sorry. When you map with CT scan, you can see this picture quite similar to what you have seen in US, but you have the very close view with this, and you can see structure more in terms of the situation. But I think this day we probably don't need this that much, except for those who want to do staging for resectability of the pancreatic tumor in terms of vascular invasion. So the next move is to check the structure in terms of the one that you look at the pancreatic head area in terms of the splenic vein and confluent. And this is the main pancreatic duct and common bile duct, as you can see from here. This is a bit different, and to the technique, we think bile duct is more difficult to find compared to the linear scope. And this is the main structure. You have the scope in the bulb, and you have this thing called the stack side. In this case, you see CBD stone inside the common bile duct. Actually, stack side means that there are three structures: common bile duct, main pancreatic duct, and the portal vein. Here, 1, 2, 3 there. What else? I think not only angiogram can tell you about divisum, but in divisum, ESP, you see the missing main pancreatic duct. So is the thing we call it incomplete stack in pancreas divisum. And with this station, you can see the cross duct side that, PD coming cross to CBD, similar to what we see in the MRCP in the pancreas divisum. So this is the comparison between divisum and non-divisum by EUS. In this one, with divisum, they have the very straight structure coming through the dorsal duct, but this you don't have because you have the dominant ventral duct. What else? The second station, you try to look at ampullary tumor. This is the ampulla. See like snake eye, CBD and PD. Okay, and this is the case that you want to take a look at CBD stone, like in this one. This is what we use quite often to find out the CBD stone before we move forward to ESP in those who has low suspicion for CBD stone by clinical presentation, and also for the patient with the ampullary tumor. What about the liver? I think we just talked to the team here about liver biopsy. So left lobe is one of the structure. Usually you start seeing at the GE junction, and some of the segment 5 can be seen. And during your C-sweep maneuver, and usually you see by long position in the antrum and duodenal station. But I think because of you cannot do biopsy with this, maybe the linear guy can tell us better. What else? I think the last part will be talking about the the EUS radial in the rectum. This is a structure in male patient. This is a prostate scan. This is the one you have to see as a landmark. For cancer of the prostate, you can see disruption of the the wall through this one as the cancer, and also for female, differently bladder, and in between is vagina. And this is the case of tumor of the rectum, and turned out to be carcinoid in this one. So I mean, to my opinion, although is not much of the need for real EUS this day, but if you have some information, you may not need to do the tissue acquisition. You still need that if the diagnosis is doubtful or malignancy cannot be excluded. So go for linear EUS. And you have the surgical resection in the plan, and that structure gonna be removed, including the area you examine. That's why seeding is a problem. But don't do that, because if you have radial feature alone can make diagnosis. And if that lesion is so small, you may not need to poke it. And if that lesion is endoscopic resectable, go ahead. I mean, doesn't matter if you want to resect by endoscopy anyhow. And lastly, if the patient is not surgical candidate, and you may not need to do confirmation tests. So in summary, ladies and gentlemen, I would say radial EUS is a useful diagnostic test in many conditions, including mediastinum, upper GI, pancreatobiliary, and rectal lesion. To me, as the the endosonographer, I think anatomical relationship is quite similar to X-ray imaging, so easy for us to understand. What I use often these days is to confirm and distinguish many subepithelial lesions because of, as I mentioned, you echogenicity and the layer of the origin. There are certain stages to perform if you want to complete examine the pancreatobiliary area. And this disease entity to examine are subepithelial GI lesion, lung cancer staging, CBD, and pancreatic stone, pancreatic tumor finding and staging, prostate, and certain gynae cancer. I think that's the end of my talk, and I give my extra 10 minutes to Dongwan and Vinay. Thank you for your kind attention.
Any questions for Rungsun on radial? I wanted to ask you, we find uncinate a little difficult area to see. You know, it's the graveyard of endosonologists, they say, because it's a difficult area to see. So I find it a little bit difficult with the radial scope, how to see the uncinate. Dr. Dheer, any comments?
I think that the problem for that area, if you want to poke and the station is not stable.
Yes. So uncinate, you will go only if you're seeing a lesion in the uncinate CT or ultrasound has picked up, and then I think a linear is a better way to go. So I think this bias will keep coming during our talks towards linear, that we started with radial, as you know, and now we hardly do radial, and especially some people like it for bile duct stones, small bile duct stones, because you don't need a biopsy. You want to see a stricture, but wherever you have a slightest need for a biopsy, I think you will not pick up your radial scope. So cancer staging, as Rungsun very rightly mentioned, we are not getting patients for T staging anymore. PET MR has really taken over. Yeah, so limited role. Pancreas, I love linear EUS. So
we do it this day. One is to train the beginner and those who don't do routine EUS, because for them to look for, I think, two things: subepithelial lesion and CBD stone. I keep scope to very young fellow, but for those who already perform EUS, I said, okay, you guys just go with linear. Yeah, but because easy and safer for us and the supervisor, okay, you go with radial. So I'm sure that they're not gonna poke or do anything seriously. Yes.
You're loud without this.
And thank you very much. That was very interesting talk. Just to go on from this topic, in Thailand, for example, when you are training your trainees, do you start them all on radial training, or are there, or do you start only on linear? Because some people might argue that if you start with the radial training, the way that you see it with your eyes will be the same as like learning to write with your left hand and then learning to write with your right hand. So I know you say for the beginners you like to use it on the radial, but going forward for training of people in EUS, would you recommend that all people are started and will only start on linear? I know this is an interesting question for you, but what do you think?
This is very practical question, and we do have the similar problem in terms to assign our fellow to perform it. our practice, but maybe we're to your opinion. We have, 3-year fellowship program. Some of them may not be finished as the, advanced endoscopies. They are motility guide and the hepatology. So those, we let them use radial echo endoscope during their second year, and that's it. But for those who want to go for advanced fellowship, we hand them with linear as the first scope they do. But because we do have these two scope, but as we understand that if you don't have, you may try with linear, even for those who want to learn. But just be careful with the moving around with the scope, because I think what we see very often is the perforation with the oblique viewing when they don't familiar with this scope.
Linear has overtaken the radial. Can it be done in the subepithelial lesions also? I mean, how comfortable we will be in analyzing, evaluating the subepithelial lesion also? Yeah, because I think linear can also be used there also. Yeah, so to actually talk. Yeah, radial. Yeah. Yeah.
The reason is that many times as a practicing endosonologist, you get referral for really, really very small lesions. And many times you have to put upper scope to really appreciate that lesion, because it has been sent to you by a endoscopist colleague. So you have to, and then you really struggle to sometime find that. For that, radial is very good. And as Dr. Dee said, that the best indication is for CBD stone. It's a very quick procedure. You don't want anything. If there is a doubt, you have stone, you don't have stone, you just put in the scope. It finishes very fast, and you can see like IMR-CP view of the CBD. So that's a very important.
Just the final comment in India, I mean, intestinal TB is very common. So another very easy indication is for radial to look at the lymph nodes around that axis. It's much easier to use a radial scope for that.
You can see, but you need to take a sample.
We do get cases for two things. One is cancer staging. MRI is very good, rectal cancer, but sphincter, how close we are to sphincter, and postpartum women who or other things who have sphincter defects. These patients come to us for EUS, and we prefer radial for sphincter evaluation rather than a linear scope. Simple. You have money, use balloon.
I still remember Dr. Dee's comment when I was a resident that the cost of the balloon those days was so expensive that he would say that you can buy 4 tires of a car in the cost of a balloon. Is it really? Because they are all reusable and they are very, very expensive.
So, yeah, it does help in certain situations. Balloon. No. Yes, yes. Sometimes you feel the need, but very occasionally. More in the beginning when you're learning, because you can stabilize the scope with the balloon. And later on, more and more as you do it, the need really disappears.
Thanks, Rungsun, for giving such a lucid talk despite you not practicing it too much. He's an expert and EUS-cipist and a colonoscopy person, so he's a master in that. So next time